Thank you guys for joining in this evening. My name is Mark Wagner. I'm going to give you a comprehensive review of biologic treatment or stem cell treatment for orthopedic conditions. And if you do have questions throughout this, if you just post them in the chat, I will go through all those at the end. And I will stay as long as we need to go through everybody's questions. A little background on me. I've been practicing primary care, sports medicine, regenerative medicine, ER medicine for over 30 years in the Seattle area. I'm the founder of Seattle Sports and Regenerative Medicine. I was a senior partner and medical director of the sports medicine clinic and on staff, faculty at the University of Washington, also consulting team physician to the Seattle Mariners for many, many years. I am board certified and a fellow of the American Academy of Family Practice and a diplomat of the American Board of Family Practice. So what do we treat with stem cells? Well, a wide variety of conditions. I'm going to start at the bottom left-hand corner and then work clockwise around this wheel. Synovitis basically is inflammation in joints. Osteochondral defects, which are kind of focal areas of cartilage damage, which then sometimes progress much more extensively to osteoarthritis. Meniscus tears, labrum tears, which, if you don't know what a labrum is, it's basically like the meniscus of the shoulder and the hip. Partial ACL tears, rotator cuff tears, chondromalacia, and tendon injuries. So now we're going to kind of talk about each of those a little more specifically. Osteoarthritis. Osteoarthritis is the breakdown of the Teflon covering of the joint. And you start to get cracks and fissures and craters in that covering to the point where it goes down and starts to involve the underlying bone. Osteoarthritis most commonly is what we call, wear and tear arthritis. It just comes about either as a result of old trauma, old injuries, genetics, but it's not necessarily as a result of an autoimmune phenomenon like rheumatoid arthritis, lupus, ankylosing spondylitis, and the different what we call spondyloarthropathies. Now, we do treat those as well. However, stem cells are not going to treat the root cause of the autoimmune arthritis. So I treat a lot of people with rheumatoid arthritis who have bad knees, and we take care of their knees, but I'm still not fixing basically the rheumatoid arthritis. That's would be a medication that somebody's on through the rheumatologist or biologic, which handles basically the cause of the problem. Osteoarthritis, very, very, very common. There's different varying degrees, mild, moderate, severe. Typically, if we find patients in the mild to moderate or even moderately severe, they tend to do really, really well. Severe, where there is no joint space at all, then percentages tend to drop off significantly. And oftentimes with those patients, I may refer them to one of the orthopedic surgeons to talk about things like total knee replacement. However, I do a fair number of severe osteoarthritic joints when they are referred to me by their surgeon because for whatever reason, the patient may not be a candidate for surgery. Maybe they've got some cardiac conditions or obesity or severe diabetes or some other conditions that would not make them a good candidate. So therefore, we will do stem cells on them. And actually, we see pretty darn good results on them as well. We treat ankles, knees, hips, wrists, elbows, and shoulders. And I also do treat sacroiliac joints. I do not do spine. The data isn't as good for results on spine as it is on joints. That's not to say that you can't get good results with spine, but I do have people that I refer for spine. Osteochondral defects. These are kind of focal areas of osteoarthritis. Could be as a result of an injury, or for some reason, the blood flow to a certain area of a joint stops. We most commonly see them in knees and in ankles. Oftentimes we see them in kids. Now, most of the time in kids, we just watch them and they basically heal and they do fine as long as their growth plates are open. A lot of people will go and see a surgeon for osteochondral defects, and one of the things that's done is called microfracture surgery. I'm not a big fan of it. I just have not seen good results with it. Those people oftentimes end up seeing me after they've had 2 or 3 unsuccessful treatments, and we'll treat them with biologics, with stem cells, and they tend to do very well. Meniscus. So very commonly, meniscus in the knee is a slightly different type of cartilage than is that Teflon covering. It's more of a buffer and a stabilizing C-shaped structure, both on the medial and the lateral sides of the knee, and oftentimes they get tears. They respond very well to stem cells, with one exception. If somebody is getting mechanical symptoms, such as locking, the knee gets stuck and they can't move it, oftentimes what we'll see is it's a certain type of a tear in the meniscus called a bucket handle tear, or a displaced fragment. If that's the case, we need to take that piece out. As much as we like to leave the meniscus there and get it to heal, if it's locking or catching, we need to do that first. And then oftentimes we will follow that up with stem cells for any other damage to the meniscus. The reason you don't want to, people a lot of times will get the impression that, they're just going to repair my meniscus. They'll put some sutures in it. Well, meniscus does not have a blood supply, so it's never going to heal, with the exception of the very, very outer 10%. Does have a little bit of a blood supply. So if you go in and you can put sutures in it all day long, it's never going to heal. So the only way you can get a meniscus to heal is by putting a blood supply there. And that's by putting cells there that can regenerate new cartilage. If you take the cartilage out, 85% of those patients are going to end up with osteoarthritis, if they don't already have it, in which case it's going to get worse. So the meniscus of the hip and the shoulder is called the labrum. It's a little bit different in the fact that it's more of like a gasket of the joint. And oftentimes we'll see tears in young patients, throwing athletes, running athletes, where maybe they don't have any arthritis in the hip joint, but they just have a labrum tear. Labrum tears in the hip are really tough to address because the hip is a really, really tight joint. And to get in and surgically do anything for a labrum tear is a really tough procedure. And you have to put 100 pounds of traction on that leg to get the joint to open enough to get a scope in. So there aren't a lot of surgeons who really like doing hip arthroscopy. But the good news is the hip labrum tears respond very well to treatment with stem cells, as do those in the shoulder. Now, oftentimes we'll get people who have osteoarthritis in their hip or shoulder, a labrum tear, and a rotator cuff tear. 3 different issues going on in the same joint. Well, the beauty of the stem cells that we use, which I'm going to get into a little bit later, is that they will treat all 3 of those issues at the same time from the same injections. So complete ACL tears, if they're completely torn, I send them to the surgeon to be fixed. However, partial ACL tears, we treat and they do phenomenally well. I've even had a couple patients. One is a Olympic silver medalist from Norway who she brought her mother actually to see me, but she had stem cells done in Norway for a complete ACL tear. And she brought me her MRIs before and after, and then I examined her knee as well. She had complete healing of her ACL. I wasn't totally 100% convinced. However, a few years ago, I did a patient with a complete ACL because she refused to have surgery. And after talking to the surgeon and myself, we thought, yeah, there might be a few fibers left, maybe, maybe not. But the patient said, absolutely not. She was a martial arts participant. And she said, I want to do stem cells. I've done the research. I want to do it. So we did her. She did really well. I lost her to follow up, but she showed up in my office about 4 or 5 weeks ago, had torn her other ACL, doing martial arts again. And I had forgotten what we did 3 years ago with her other knee. And I said, well, I'm going to send you to the surgeon. She says, no, no, no. She goes, remember, we did my other knee for a complete ACL and it's 100%. It's stable. It's fine. She goes, I want to do, once again, I want to do the stem cells for this ACL. So after a lengthy discussion, we did do it. It's only been like 3 or 4 weeks, so I'm waiting to see her back. But for the most part, I treat partial tears, ACL tears. It would be a discussion for complete tears. Rotator cuffs. Once again, if there's an acute complete tear, somebody had an injury, they fell, they did something, they can't lift their arm up past about 60 degrees, that's got to go to surgery, and you have to go ahead and surgically repair those. However, if somebody has a partial tear of their rotator cuff, stem cells work significantly better than surgery. Typically, in the area where people get partial tears or complete tears, it's in an area called the avascular zone. And it's an area of the cuff that has a really poor blood supply where the muscle becomes tendon. And so if you go in and try to repair partial tears, you put a bunch of sutures in there, well, you compromise the blood supply even more. And 60 to 90% of those surgeries fail within 5 years. Whereas rotator cuffs treated with stem cells do phenomenally well. And it's a quick procedure. You're looking at patients, 85% of them are thrilled with their results. In my hands, 91% are thrilled, but 85% is big data. Also, complete rotator cuff tears that are chronic. Say it's been 6 months. Somebody tore it, 6 months ago. They've got arthritis. They got a rotator cuff tear. Yes, I treat those as well. However, the ends are not going to come back together. But usually once it's 6 months has gone by, surgery is not going to bring those ends back together because the muscle and tendon atrophies and pulls away. So the stem cells work really well with pain, range of motion, and strength. But once again, it's not going to bring the ends back together. Chondromalacia is basically kind of a precursor to osteoarthritis where just that Teflon covering in the joint is damaged, but we don't see underlying damage yet to the bone. Oftentimes we see it in runners, running athletes, behind the kneecap. And once again, it's one of the things I love treating. They do really well. It's a non-weight bearing portion of the joint. Tendon injuries. So most of the time when I do tendons, Achilles tendons, patellar tendons, and then like elbow, tennis elbow, golfer's elbow, I usually start out with just PRP, which is platelet-rich plasma, unless an MRI indicates that somebody has partial tears in the tendon. If they do, I will use bone marrow aspirate and platelets. I've seen a number of significant Achilles tears, not complete, but high-grade tears that I've treated with stem cells, as well as patellar tendon and quadriceps tendon. And they're back playing tennis, playing golf, hiking, and doing just fine without having to have a big surgery with a 6-month recovery. Synovitis, inflammation in a joint. That's how the synovium is the tissue that lines the joint. And sometimes it just gets inflamed. It could be from trauma. It could be from overuse. Where I see this the most, women runners who have had physical therapy, they've had cortisone injections, sometimes they even had scopes, they have normal MRI, normal X-ray, and they come to see me and they want me to do stem cells. And I say, I think we can get by just by doing PRP. And they 100% of the time do just great with PRP and don't need anything else, and they get back to running and all of their activities. So now we'll talk about, what's happening with these stem cells. So what is regenerative medicine? The study that utilizes stem cells to heal and regenerate damaged tissue. The use of autologous, meaning from your own body, adult mesenchymal stem cells to regenerate bone, cartilage, muscle, and tendon. So what a stem cell is, it's an undifferentiated or unspecialized cell that has the ability to renew itself and also transform into different cell types within the body. When we were 10 years old, one out of every 200 cells in our body was a stem cell, kind of circulating around in our bloodstream. Well, when you hit 60, about one out of every 200 million cells is a stem cell. And if you have osteoarthritis or severe inflammation in a joint, you have hardly any stem cells within that joint. However, we're fortunate in the fact that we still have these localized areas where you have high concentrations of stem cells, even at advanced age. Big question a lot of times people is, well, I'm 80 years old, do I have any stem cells? Do I have enough? And you have plenty. Long bones, any bones, basically, where we can get into the marrow, we can isolate stem cells. So what do stem cells do? They do two things. They stop the inflammation. They stop the itis on the end of arthritis. So they stop the joint from getting worse and breaking down more. Then those cells go through this pathway. It's called the Indian hedgehog pathway, which I still have been unable to find where that came from. But and they become adult. Well, they differentiate into different cell types. The cells that we isolate from bone marrow and fat are called adult mesenchymal stem cells. We're able to just get those cells. Those are the only ones we want. We don't want 206 different types of tissue. We want the ones that are going to grow up to be only muscle, tendon, cartilage, and bone. And if you have a joint that needs muscle or tendon or cartilage, those cells know what to do and who to grow up to become. They're not going to put the wrong kind of tissue in the wrong place. They're like little general contractors. They know, okay, we need to do a little drywall repair up there, but we got to put a strut over here and we've got to do some wiring. They know what to do. We can't program them. Elon Musk will figure it out someday, but they just have this great intrinsic ability to do that. The cells that we want, and about 5-6 years ago, a buddy of mine who ran the molecular biology department at Stanford came up with this software program that runs our centrifuges that just isolates out that particular cell in billions, which is phenomenal. To me, that was a game changer. I was using a company out of Japan to harvest and concentrate stem cells, and now we're getting so many orders of magnitude higher numbers by using the system that I use now. And I think that's so unique to what anybody else out there is using. So what are the options? Oftentimes, so many times I have patients come in and they say, well, the surgeon told me I'm bone on bone and I got to have a total knee replacement. And I'm not thrilled about that at all. Well, I would say 90 some odd % of the time that patients come to see me and they are under the impression that they're bone on bone. Even they bring their films in on a disc and I say, well, let's look at them. They're not bone on bone. It is a term that gets thrown out so loosely that patients hear that term and they're like, oh my God, I've got to have a total knee replacement. Well, here's the big data on total knee replacements. 65 to 70% of patients who have total knees are happy with their results. But that means 30 to 35% are not happy at all. And it can be worse afterwards. I probably see 3 or 4 patients a month who come to see me because they had a failed total joint and a year ago or 2 years ago or 5 years ago, and they're miserable and they come because they want me to do stem cells. And I said, well, Not much I can do now because all you got in there now is metal and plastic. So it's a good. We'd love it if we can get to patients before they make a big investment into a total knee replacement. Some of the complications that you can see with total knee replacement: infection, blood clots or DVTs, which can oftentimes break off and go to your lungs, and that's called a pulmonary embolism. There's a couple studies out that say that men and women over the age of 60 have 30 times greater and respectively 25 times greater incidence of heart attack and stroke in the 1 year following a total knee replacement. The reason being, you think about it, it's a big surgery. We're amputating an entire joint. There's a lot of bleeding. Subsequently, there's a lot of clotting. Sometimes those clots make their way back to your heart and brain. Total knees and any total joint doesn't last forever. Knees anywhere from 8 to 15 years, depending upon your size and your activity level. And then they have to be redone. And revisions never turn out as well as the original. Other thing is that there are some studies out there now talking about increased incidence of dementia with joint replacements. And that is because of cobalt, chromium, nickel, and titanium, or what we call metallosis. They leach into your bloodstream. I'll go back here actually. So it's a big surgery. It's a year of rehab. Rarely will anybody do both knees at the same time because you're fairly incapacitated for quite some time. And if your BMI is over 28 or 30, you're at quite a bit significant increased risk for all of the complications that we see. Okay, so stem cell procedure. Before the procedure, we see patients in the office for consultation. We tell them no anti-inflammatories a few days before and then for 6 weeks after. The reason being is the way that we heal is by virtue of inflammation. Okay, so we want inflammation in that first 6 weeks. We tell patients to drink a lot of water, 64 ounces that day before, just to make the draw for the PRP, the blood draw, easier. As far as medications, patients can stay on all their medications with the exception of blood thinners. And it's iffy. Sometimes I let people stay on their blood thinners. Sometimes we take them off for a couple of days. Depends on which joint we're doing. So we draw blood first. The sample goes into the computerized centrifuge and we isolate platelets by virtue of the fact that the platelets basically get concentrated into an area called the Buffy coat. We pipette off the Buffy coat. We set that aside. I then do the bone marrow extraction. Where I do that is what's called the posterior superior iliac crest. So basically you've got your spine and then you have your pelvis on both sides. That's where we go take the bone marrow. It's usually what scares patients the most. I have done well in excess of 20 some odd thousand bone marrow extractions. It takes me less than a minute to do a bone marrow biopsy or extraction. Half the patients we do it on are like, you kidding? You're done already? And half are like, oh, wow, that feels like sciatic nerve pain going down my leg or a deep hollow ache. But if you're in that half that's painful, it's going to last about 30 seconds. And once that needle is out, the pain is gone. We then, kind of in the love handle area, do a mini liposuction, and then we extract the stem cells from both the bone marrow and the adipose. So then we've got 3 syringes, one with the platelets, which is PRP or plasma-rich platelet-rich plasma. 2 is the bone marrow stem cells, and 3 is the adipose stem cells. Then I use ultrasound to guide my injection. It's 1 needle and then switching out 3 different syringes. That takes a minute or 2. It's not a big deal. Who do we not do the procedure in? If somebody has an active infection, they got sinus infection, they got pneumonia, anything going on like that, skin infections, we don't do it. If somebody is being treated for cancer or has cancer with metastasis, I do not do the procedure. Prostate cancer is fine as long as it's localized. The That's pretty much it as far as contraindications. Um, one of the things I want to talk about is there are people out there. It seems like mostly there are these kind of groups of naturopaths and chiropractors who do stem cells, but they do what we call allografts. So they're not taking them from the patient, they're buying them online. Those products come usually from south of the border. They come from women who are willing to sell their placentas. They're either amniotic or embryonic. And there are zero live stem cells in that product. They're desiccated, a white powder. They're reconstituted with sterile saline, and they're usually injected by a nurse or a nurse practitioner that the group hires to do that. I've seen some really, really bad results with these. I mean, to the point of one patient ending up having a above the knee amputation after he'd had it done with this group using stem cells from elsewhere. I mean, anybody can buy. You can buy them online, but once again, no live stem cells, and God only knows what else is in there. So you want to be really careful about seeing somebody who does a ton of these, who's board certified and well trained in the procedure, and only using autologous, meaning your own stem cells. So results. Patients with mild to moderately severe osteoarthritis, big data says 80 to 85% of patients see at least 75 to 80% improvement. In our patient population with over 20,000 cases, 91% of our patients are at least 75% improved. So I'm just going to kind of go through fairly quickly. These are just from some major, mostly orthopedic journals. These are the conclusions of some studies. There was evidence of meniscus regeneration and improvement in knee pain following treatment with human mesenchymal stem cells. These results support the study of human mesenchymal stem cells for the apparent knee tissue regeneration and protective effects. That was from the Journal of Bone and Joint Surgery. From the Journal of Clinical Orthopedics and Trauma, the versatility of stem cells as a treatment modality has landed it another repair target, osteoarthritis. Through many studies, this newly discovered method has been shown to significantly alleviate pain experienced by osteoarthritis patients. From Helion, this study showed that a single intra-articular injection of bone marrow stem cells appears to provide long-term benefits. The procedure is simple, fast, well-tolerated, avoids the need for hospitalization, and generated no complications or adverse effects. Yeah, I'll just mention the procedure takes about an hour. It's local anesthetic. You're awake, you listen to music, you walk out, you do need a ride, and then typically we start physical therapy the following week. Journal of Orthopedic Translation. In contrast to traditional treatments based on drugs, proteins, or antibodies, stem cells are poised to revolutionize medicine as they possess the capacity to replace and repair tissues and organs, such as osteoarthritic joints. In conclusion, this is from Nature, the British Scientific Journal. It's kind of like their New England Journal of Medicine. In conclusion, mesenchymal stem cell treatment improves knee pain, physical function, and cartilage quality without any adverse events. Cartilage mapping by MRI showed evidence of improvement in the good cartilage quality and significant decrease in poor cartilage quality. Basically, this was treatment of osteoarthritis and osteochondral defects, where they went back 2 years afterwards and did scopes to look at the areas. And they showed some of the scopes. Well, first, I would say first the MRIs did show complete filling in 12 of 15 patients on a 15 patient population. And then when they did actual arthroscopy at 2 years, they saw smooth, newly formed tissue, and that the implant stability was similar to the natural tissue, the native tissue that was there. This is just a study that showed that basically for these osteochondral defects in the ankle, that stem cells are significantly more beneficial than doing microfracture surgery. This was a big study. It basically reviewed, it came out of NIH, National Institute of Health, and two Harvard guys that did this. Basically, they found that in light of its excellent safety profile and the absence of other safe, effective treatments for osteoarthritis, AMSCI, which is mesenchymal stem cell injection treatment, should be widely adopted for the treatment of osteoarthritis. So there have been now over 40 million cases done in the US. There have been 0 adverse events reported on the FDA database as long as you use your own cells. And it is just very nice to know that there's no general anesthesia, which oftentimes people do have complications with. Afterwards, it's just ice, taking it easy. We tell people, walk, use the joint, but don't overuse it. We avoid the anti-inflammatories, and we start physical therapy usually the following week. Most people start to see significant improvement in the 6 to 12 week range. However, some people within a couple days notice improvement. I had 2 people I called this morning who had their procedures done last week, and they said, I don't know, am I just crazy? But I'm not feeling any pain at all. My knee feels like it hasn't felt for 10 years. So, sometimes that happens. It can be just the anti-inflammatory effects. It could be the buffering of sometimes the matrix of the fat kind of lubricates it. But typically I tell people that first, few weeks, things can bounce all over the place and they can be a little stiff and sore. So that's pretty much all I have for right now. But now I'm happy to kind of go through everybody's questions, and that'll stimulate quite a bit more conversation. How long do you have to be off anti-inflammatories? Before. I tell people 3 to 5 days to be off anti-inflammatories before the procedure, and then for 6 weeks afterwards. And somebody's asking duration of benefits. So Bornstein at Harvard, she's been doing this longer than anybody. I think she's at like 18 years. She's got patients who were scheduled for total joint replacements who were doing just fine 18 years out. She also has patients who she says, come back at 10 years and said, Doc, my knees, my hips, they've been great. They're starting to bother me. Can we do it again? And there's no problem. It can be done again. I've been doing this about 9 years, 8-9 years. And I've done a couple people where I've repeated them. Mostly it's cases where somebody was like in a car accident and it impacted their knees on the dash, or, kept running, ultra marathoners who just constantly damage the joint and they want to come do it again. But for what we'll do sometimes is just something called a PRP booster, where we put some more platelets in. It's kind of like putting more fertilizer on the seeds. Let's see. Okay, so it says this is for ankle joints. I've been waiting for stem to develop further. Is there a decreased chance of success, generally speaking, the further out one waits? Bone on bone being the final stage. Yes. So the big thing is the earlier we catch, osteoarthritis, mild to moderate, the better people do. If you have issues, it's best to jump on them as soon as possible. If you wait too long to the point where you start to develop like damage to the bone, cysts in the bone, no cartilage whatsoever, then, especially in an ankle, then you're looking at, oftentimes the only option is an ankle fusion, which is, it's not a great option. Um, so why is this not? Oh, so is that all the questions?
Mhm. Mhm.
Okay. Can you do stem cell therapy on inflamed wrist joints? Yes, absolutely, you can. We do wrists all the time. Oftentimes the base of the thumb, the first CMC joint we do, but then also throughout all the small little bones in the wrist and for osteoarthritis. Because with wrists, oftentimes the only other option is fusing either part of that joint or all of that joint. Um, and then we've got how much does it typically cost? It's not covered by insurance. Um, Typically, a large joint is, well, it depends, between 5 and 10,000, depending if it's one joint or two joints, large joints, small joints. So everything varies basically. Um, Sounds like it is great for knees. How well does it work for hips? We do more knees and then followed by hips and shoulders. Um, Hip replacement surgery in a month, but would love to have another opinion or another option. Yeah, that would be something to just get your films and make a appointment for a consultation. And if I look at it and I think you need to have surgery, I'm going to say go ahead and have surgery. If I think that you've got a good chance at doing well with biologics, then I'll be perfectly honest with you on that. So yeah, insurance does not. So I'm looking at some of these questions. It is considered FDA investigational and FDA cleared, but there's a lot of politics that go into approval there, and oftentimes it has to do with the fact that total joint replacements, are financially very beneficial for hospitals and ambulatory surgery centers, and are significantly more expensive. So yeah, there is a lot of politics out there. Basically, if you look at places like Mayo Clinic, Cleveland Clinic, Johns Hopkins, Harvard, Stanford, USC, I mean, Case Western, they're all doing stem cells because they work. Um, who is a good candidate? Who is not? Anybody who's got mild to moderately severe osteoarthritis is a good candidate. Um, People who are not, it's not like the things like obesity, diabetes, heart disease. They are not limiting factors for stem cells where they are for surgery. Um, Says, how about age issues? Patient 87 years old with bad knees. I mean, we've done over 300 patients in their mid 90s who've done just fine. Um, Arthritis at the base of my thumb. How soon after the procedure will I be able to ride a bike? Um, Typically, I actually have exactly the same thing. I did my thumbs about 8 years, well, yeah, 8 years ago, and it was just a game changer for me. So you can usually get back. I hadn't done, and I actually was riding a motorcycle at the time. An hour after the procedure, I basically rode. But the things that I tell people to avoid afterwards are things like screwdriver, hammering, shouldn't be doing handstands. I wouldn't be, playing tennis right away. It's more heavy repetitive motion in the wrist. Somebody wants to know if you can do both knees at the same time. Absolutely. Because you're walking. It's not like you're incapacitated afterwards. Yes, somebody else asked some thumb. We do a lot of thumbs and we do a lot of toe joints, like bunion areas. Wrist joints, absolutely. We do a ton of wrists. So unfortunately, somebody's saying, is there a refund policy if the treatment doesn't work? I wish I could tell everybody it's 100% slam dunk guarantee, but it's not like anything else in life. So there is a, basically on average, it's usually 9 to 15% of patients may not get, the results that we were hoping for. But the nice thing is nobody gets worse. And that's the big difference between that and surgical procedures. So people are just wanting to know, for consultation, should we bring our MRI results? Absolutely. Hopefully they're within a year. We can fudge it if it's, just a little more than a year. But yes, I always tell people bring, if they can, the disc and the report, because I like to see both. Typical cost for a shoulder, so any large joint is usually right around $7,500. Bursitis does get benefits. Usually with bursitis, I'll probably just do PRP because it's less expensive and it's usually all we need to do because we're not trying to regenerate tissue. The cost of PRP is usually about $1,000 to do a joint. Yes, we'll make a copy of this presentation. If we have everybody's email addresses, we will send out a PDF. Or no, actually, this is going to be on YouTube, right? Are we putting this on YouTube?
We can.
Yeah, we'll put it on YouTube and you can get it that way, but we'll also send a PDF copy of a very informative brochure to everybody. I've been told that I need to have L1 to L5 fused. Does this eliminate me? Well, only because I don't do spine. But if it was in reference to a joint, it wouldn't have any effect. Somebody said, I have a recent tear in my knee meniscus. I'm a runner. I want to continue. Can stem cell therapy regrow the meniscus tissue and allow me to run? Yes. We do lots of patients, as long as you're not getting mechanical symptoms like locking in that knee joint. I was told my meniscus tore from the bone. I was given 3 options: surgery, which they said 50-50 chance of recovery, partial and full knee replacement. Because of my age, 55, weight, and moderate osteoarthritis, they recommended partial knee replacement. Would you recommend stem cell therapy with 50-50 surgery or stem cell to see if my meniscus repairs? I would like to see the MRI. I would like to examine the knee, but kind of what I'm just seeing in this little bit of information, be a very good candidate for stem cells. Certainly with a partial or a total, you're not going to get back to running, but I think with stem cells, depending upon what I'd see on your MRI and your exam, I think there's a good chance that you could. Exosomes were very big in the NFL a few years ago. It's like professional athletes, and it's like somebody gets exosomes and they in the world, and then I end up seeing a lot of NFL guys who all want to do exosomes. Exosomes basically are the text messages that stem cells send to different tissues in the body to kind of stimulate healing. The exosomes themselves, limited results with them. The stem cells, when you do stem cells in somebody, you're putting exosomes there as well. Stem cells in PRP tend to work significantly better than exosomes. Where I have done exosomes is in patients who've had stem cells in the past and they want like a booster of platelets, or they want to kind of ramp up their healing, then sometimes we'll try the exosomes. But it's kind of fallen a little bit out of favor. Is this a one? Yes, it is a 1-day procedure. It takes you'll be in the office no more than an hour and a half. The sting, the blood draw, the bone marrow, the adipose is all harvested at the same time. So everything is done in one visit. Does stem cell procedures prevent other surgeries or other major health events? Care. So yeah, the hope is that we're preventing having to do big surgeries by using stem cells. Now, stem cells are being used more and more by a host of different physicians. Cardiologists use them to repair damaged heart tissue. The neurosurgeons use it for there are quite a few studies right now for Alzheimer's, ALS, dementia, and Parkinson's, spinal cord injury. There, as of like 6 months ago, there were 2 cases in the Lancet, which is the British medical journal, of cures for type 1 diabetes. The dermatologists and cosmetic surgeons use it all the time. So we had somebody else who said, I had embryo stem cell treatment with limited results. Should I worry with those stem cells in me now? No, because they were all dead when you had it the first time. So all you had basically was the growth factors that was in the plasma or the fluid. So no, nothing to worry about. If you had limited results, it's not surprising. So if you're still having issues, you'd want to do it with your own cells. And I had imaging done on my shoulder by a sports MD. Not sure if there was anything. I could watch the image on a screen. Oh, so it sounds almost like it was either ultrasound or fluoroscopy. Um, Kind of the gold standard for shoulders is an MRI/arthrogram. So in other words, we inject dye into the joint. That's what I do for shoulders and for hips because it shows us so much more information as far as little tears in the labrum. Recently, I had a friend that recently had Synvisc 1 injections. He said it was working great. So Synvisc was the first of what we call the viscoelastic supplements. Now there's about 15 or 20 different ones. It is hyaluronic acid. It actually was discovered from the comb of a rooster. That's where it comes from. And it is literally putting Pennzoil 10W30 weight into your joint. It lubricates the joint. It used to be covered by insurances, but in July of 2016, 2 big studies came out that said it's effective in about 50% of patients, and if it's effective for 6 to 12 months. So all the insurers dropped it. Nobody's covering it except Medicare. I do a bunch of those injections. It's basically like bringing your car to Jiffy Lube. It lubricates the joint. We'll do it oftentimes after stem cell. It's not going to regenerate any tissue, but it does kind of give people some relief. Financing, we tried to do this thing called Care Credit, but we found out that they tack 20% on and then they charge like 29% interest. So what most people do is they say, you know what, I'm going to go to my bank, I'll get an interest-free credit card and I'll just make my own payment plan. And it's a lot less expensive. I have a bad shoulder. How much physical therapy do I need after stem cell? Typically, I have patients start twice a week for 3 to 6 weeks. Rarely do patients go past 6 weeks, but if they need it, certainly that's something that we do. Do I work with patients outside of Seattle? We see patients from all over the world. We have patients fly in, have the procedure done, and fly out. We see a lot of patients from Asia. I actually I saw a whole family this morning that came in with their dad from China. We see patients from Malaysia, from India, from Europe, a bunch of patients from Iceland, a lot of patients from Canada, but all over the United States, we have patients that come in. Do I need to have a formal diagnosis before a treatment? No, that's something that we can do. We have imaging facilities in our office. Certainly, patients come in usually to see me and get an exam or consultation. If they don't have films, we can do it at the office. If they need an MRI, we can get that done as well. My second knee is going out. I don't want another knee replacement. Yeah, I don't blame you. I would say, set up a time for a consultation and we'll see if stem cells are an option at all for you. 3 joints at the same time. If there are 3 large joints, it's somewhere around 2019. Does your office work with motor vehicle injuries? Yes, we work with motor vehicle injuries all the time. As far out, my front desk knows that if patients can't get in within 2 weeks, unless I'm on vacation, they come and find me, and I will take an earlier boat in, or I will stay later, or we'll see people over lunch hour or whatever. So we always try to get people in within 2 weeks. Same thing for procedures. We try to get people in within 2 weeks. I had meniscus root repair surgery, then tore the meniscus itself, told the next step is knee replacement. Absolutely, stem cells is an option for you. My clinic, it's just one clinic. We're in South Lake Union at 1000 Dexter, and it's Seattle Sports and Regenerative Medicine. And like I said, we'll get everybody's email or some tech. What are they? And we'll send out a packet of information to everybody on this who was here tonight. So imaging options for those who cannot have MRI due to implants. Sometimes X-ray is enough to be able to see what we need. Sometimes CAT scan. It all depends what joint we're talking about. Sometimes ultrasound. But certainly that's something we work with all the time. If you are wanting to inject for a meniscus, I'm assuming you need to do an MRI to map the location. No, the meniscus is in the joint. And when we go in and we do the injection, it's in the joint. So it goes everywhere that it needs to go within the joint. So if somebody, if their knee exam, jumps out to me and says meniscus tear, and they don't have any instability in the joint, they don't have any locking, but they've got pain, oftentimes I'll give patients the option. I'll say, we can do an MRI. However, if it shows a meniscus tear, it's not going to change my treatment plan. But some people just say, hey, you know what? I want to see an MRI. So I'm happy to do those. Or some people go, you know what? I don't want to deal with the time, the expense, and getting the MRI. I know it hurts. I know I probably have a meniscus tear. Let's just get it done. Can you save and use stem cells at another point? No, because we're not a cryogenic facility. We don't have the ability to freeze stem cells. And there's big legal issues with that now because of some California attorney general who claims that some of these clinics where they're preserving stem cells cryogenically, that because they're, I guess by legal definition, there's some question as to are they altered at all? And if they are altered at all, then they become a medication. And so now people are running into problems getting those stem cells back because of this big legal case that's out there. And it might be going to the Supreme Court. How many joints can you do in one visit? 3 large joints, sometimes more than that as far as small joints. A consultation, I want to say a consult is somewhere around $250 or $300. It all depends how many joints, but those are covered by insurance. Physical therapy is covered by insurance. Follow-ups are covered by insurance. Medicare does not, that Medicare covers consultations, but it does not cover the procedure itself. So if anybody else has any questions, go ahead and fire them off. Somebody saying the cost is somewhere between $5,000 and $10,000, depending upon, number of joints, size of joints. Somebody saying, do you, question about if you need an MRI for a hip, not a knee. Yeah, oftentimes, unless the X-ray shows me significant osteoarthritis, then we don't necessarily need to do an MRI. But if we're looking at a joint and I'm like, oh, your X-ray is normal, you might have a tear in the labrum, then I usually like to get an MRI. It says, would this procedure help a person whose leg tendons seem to be shortening, possibly Charcot-Marie tooth? Probably not, unless there is some tearing in the tendons that is causing scar tissue and causing them to shorten that way. Um, Somebody's saying, do you mix with steroids? Never, because steroids are anti-inflammatory. They would stop the whole process. The other thing, the reason you do not want to inject steroids into joints is in the long run, it breaks down the cartilage even more. So, not a good idea to put steroids into, especially weight bearing joints. Lichen planopolaris. I guess I need a little more specifics on that. If that's plantar fascia issues that you're having, and somebody's saying, does insurance cover the MRI? Typically, yes. Already had rotator cuff surgery. Can you still get stem cells? Yes. And will it help a completely torn tendon? If the tendon is completely torn and pulled apart, it's not going to bring the ends back together, but it will oftentimes help significantly with pain, range of motion, and strength. Hair loss, PRP works pretty well in some people for hair loss. I don't do cosmetics, but there are a lot of people out there at like dermatology clinics and plastic surgery clinics where it's being done. I have a medial subchondral collapse of the knee from a prior accident, which has now become bone-on-bone arthritis. Yeah, I'd like to see the films because it may or may not be bone-on-bone, and I'd like to see the size of it. But I do a lot of these that are good candidates and do very, very well. Peptides, I mean, I tell people on peptides, there's no good, strong, robust data out there to say that peptides help. We don't think it hurts, but there just hasn't been enough studies out there yet to recommend peptides. And somebody's saying replay. We'll put this on YouTube, so if you pull up my name and stem cells, it'll be there, as well as there's some other grand rounds and such that I've done on like knees specifically and shoulders specifically. More stems, the better the result. Yeah, that's why, we're going to get, if I have somebody who's 6 foot and 30 years old, I'm going to get, around 4 billion stem cells. And if we have somebody who's 95, we may get a billion. But, it's all relative. So, yeah, the more we can get, the better. And that's the beauty of this system, that gives us orders of magnitude higher from anything else that's out there being used. Right. Well, I've gone through CPT code. Somebody's wondering. It all depends on what the joint is and what the diagnosis is, but that's certainly something our business office can get for you. So here, I had arthroscopic surgery 11 months ago to trim away torn meniscus in my right knee. Still in pain, crepitus, forced steroid. Oh gosh, that's yeah, that kind of upsets me. First of all, if you have osteoarthritis in a joint, we've known for 15 years that if you go in with a scope to try to do meniscus surgery, that 15% of patients are going to be better at 1 year. Greater than 50% will be worse at 1 year. And 4 steroid shots in 12 months, that shouldn't be done. So yes, I would absolutely schedule a consultation and see, what your options are. Is it silly to ask you how you would know of osteo versus rheumatoid arthritis? Yeah, blood test. Oftentimes when patients come in, they're already diagnosed with, with rheumatoid arthritis because they've had blood panels and they've seen rheumatologists. Can you use your family member like young son stems? No, we're not set up to do that. You have to do matching and make sure that, thing is, kosher, and it's just not something that we do. Is plasma always a part of the stem cell injection? So PRP, which is the plasma, with the exception of small joints in the hands and the feet, pretty much always do PRP with bone marrow, with fat. So all three together is the gold standard. Small joints, sometimes we'll just do bone marrow aspirate. All right, I think we've gone through all the questions. I'd like to thank everybody for attending. And once again, we'll send out information, more information to everyone.